the idea behind the Your Life Depends on It series is to be at the intersection of a place where I find incredibly fascinating. That's the intersection of medicine and psychology. So I'm originally a psychologist, but I'm still a psychologist and forever will be. That's what my PhD is in. But I'm fascinated by health behaviors and behavior change. And I really think that's a fascination, that's a mission, that's a whole lot of things. And we'll talk about that a bit more. We are so lucky to have with us today Dr. Arlen Mayers, who's probably the most energetic physician you will ever meet. He is the CEO and president of the Society for Physician Entrepreneurs. And we'll speak with him at the second part of the webinar, where he'll talk to us about various initiatives that he has on his plate. So where do I come from to this mix? I started with a postdoc at Princeton University with Nobel laureate Daniel Kahneman, who I'm sure you all know. I taught consumer behavior at Wharton, and we'll talk today a little bit about consumer behavior, because when I start teaching, the first classes are on exposure and memory, and the students think this is like the biggest downer ever. Who cares about memory? It's such a basic cognitive process. And then they understand why this is really important and fascinating. And I'm a visiting researcher at the University of Cambridge, and also an associate professor at the Anu Academic College. I've been doing a lot of work with the industry, with pharmaceutical companies, sometimes directly, sometimes through health advertisers. First one was with J&J when we tried to curb chronic disease, and that was a major success, which is why nobody has chronic conditions anymore. But we all know that you can have the best idea, and that's still not going to make a huge difference. I've been very fortunate to work with a number of agencies. One of them was FCB, that's where I met Liz. Another was In Touch, that's where I didn't meet John, and a number of others. And I was also an entrepreneur for a startup where we tried to change health behaviors through really understanding people's barriers. So what do they know about their health? How can they change it? As well as what tools are we giving them? Are we just asking them to, hoping them to make a difference, or are we helping them figure things out, as well as taking care of their well-being, of their willpower, of their mind clutter, as we like to call it, and various other things in order for them to really make a difference. That was a great startup. We were part of the Alpha Zone IBM Accelerator, but it's not with us anymore. And as part of my industry involvement, I was also a mentor for Microsoft Ventures and others. That's not all I do. I'm an author. I write many academic papers. And even though my daughter says, "Mom, nobody reads your papers," she is wrong. This is the Google Scholar, the top of the page, including my paper with Daniel Kahneman, brag alert. I write for Psychology Today. I've been doing that for a long time now on various topics, mostly around health. And in September, I'm publishing, or rather Hachette Basic Books are publishing my book, Your Life Depends on It, What You Can Do to Make Better Choices About Your Health. And that's a book where I wanted to give the world my knowledge. And actually what happened is that I gained a lot of knowledge. I understood a lot about how health is served to us and what makes us behave in certain ways, much more than I ever realized was the systems component to it. And I actually ended up probably learning more than I'll ever be able to teach anyone. Today, we're talking about removing barriers to patient action, behavioral economics. And in the spirit of COVID being a lemon, or a bunch of lemons landing on us, and we need to make lemonade out of them, right? I wanted to talk about two barriers to joining a webinar. One is forgetting. And I remember sitting at the hairdresser's not so long ago, receiving an email saying, there's a talk by Diane Mayer, and she's phenomenal. She's the mother of palliative care. She won a MacArthur grant for it. The talk is starting in 30 minutes. I'm like, oh my God, I'm at the hairdresser's, but I have to hear Diane Mayer. I got the email. Of course, I didn't pay attention. Of course, I would have completely forgotten had they not shot me an email. That's why I blasted emails, so that you would not encounter this problem. Also, the confusion between the registration link and the Zoom link. I want to say I'm human. That's no excuse, but it happens, and it happens to all of us, and it happens to people with the best of intentions, because I worked super hard on this webinar. Obviously, I didn't intend to mess up the registration, and there you go, Zoom and life get in the way. So that's a long-winded way of saying I'm sorry for the confusion, but also saying with the best of intentions, things get in the way. And that sounds incredibly unprofessional. This really what it sometimes boils down to. So this is what we'll be talking about today. The say-do gap in health, psychology, and some behavioral economics explanations. There'll be embarrassing moments, mind you, but that's fine. How we can reduce the gap through removing barriers to action. I'll talk a lot about that, and how the gap is reduced through innovation, and Arlen will do the talking there. So marketers use intent data. This is for B2B marketing. They look and they think of who can I target? What are the accounts I need to target? Because there's intent, right? And we also know that the intent doesn't always happen. It doesn't always come into fruition. In psychology, this is called the theory of reasoned action. It was developed by two very smart people, neither of which was a psychologist, called Eisen and Fishbein. They were more on the mathematical side of things, and I think they just tried to understand why the heck people make such a mess of what they say they do, which is not at all what happens in physics. And what you can see here are very upstream things, like behavioral beliefs that lead to attitudes, normative beliefs that lead to subjective norms, both of which lead to our behavioral intentions. And when I say upstream, I say that because down here, we have other processes that can happen, be it exposure, be it, as I said, memory, and sometimes it's just convenience. So even when we have our behavioral intentions, ta-da, something gets in the way of us actually acting on our behavioral intentions. Let's have a little show of hands here, or you can vote using the hand on Zoom. So we're all smart people, we're educated. We decided to dedicate an hour of our time for a webinar on removing barriers to patient behavior. If we exercise all the amount that we need to exercise, let's have our hand up. And let's keep it up if we abstain from drinking to the degree that the WHO wants us to. And let's also keep it up if we don't smoke. And why don't we also keep it up if we take all of our medication always on time, right? Get enough sleep, yeah, hands still up. How many hands are we going to have at the end of the day? If I keep on asking, or even if I stop now, zero, Lynn says zero. I have to say at one talk, there were 3 Orthodox Jewish women and they kept their hands up. But that's like 1,000 people that I'd asked, so, or more. There you go. Smart people not acting on their beliefs and knowledge. What is going on here? This is a question that the WHO asked, and they asked Noel Brewer of UNC to respond in 2017, talking about vaccinations. That was about the HPV vaccine. He's a great expert at that. And I want to highlight 2 things. One is practical issues to know where the vaccine is available, previous uptake of adult vaccination, ease of access, preferred site, availability of on-site vaccination. None of these things are high-end psychological mechanisms. And we've discussed high-end psychological mechanisms in the previous webinar, and we will in upcoming webinars. And this one, I just wanted to share with you what we can think of as the low-hanging fruit, and to see that sometimes it's not enough people are picking those low-hanging fruit. Another way of increasing vaccination is obviously through nudges, and we're not exactly talking about them now, although we can expand the concept of nudges and say if you increase access, that's a nudge. We can argue about that, but we really don't have to argue. We can just look at how to remove barriers to patient actions. So when we talk about vaccinations, and I want to talk about COVID for a moment, and we'll stay with COVID a little bit and then we'll move on to other things. we can see that when this was taken, when 19% of the population was vaccinated. So you have 32% who say, just say when, I'm dying to vaccinate, I'll drive an hour, I'll drive for 2 hours, I'll wait in line, I don't care, I'm gonna do it. Then you have 17% who need a push. For these 17%, I think those are the people we're discussing today, who need the push, and it can be mild. And if they get it, they're going to act upon their positive attitude. There are those who need massive persuasion. They're tougher nuts to crack. And there are those who will say, I will not vaccinate. There was a New York Times picture with Bill Gates, you have to kill me to vaccinate me. That's very grim attitudes there that I really don't know how to change, but that's not what we're discussing today. What we're discussing today is how to remove barriers, and we can see one way of removing barriers, having people vaccinate at Walmart. So you know where Walmart is. It's not some clinic that you have to find. It has a positive connotation. It also has a bit of a reward because the benefit is not only getting vaccinated, it's actually also getting to do your shopping. So that's one way of removing a barrier. Another that was done in the UK was to have a vaccination bus. The bus comes to you if you live in a rural area. There you go. You didn't have to drive. You didn't have to look for parking. You have it. Go get vaccinated. And that's great. But that is definitely not a one size fits all, because moving on from COVID to mental health, we know that 60% of young people with major depression received no mental health treatment in 2017, 2018. We also know that 40% of students suffer from anxiety and 40% suffer from depression, thankfully, if I can say that, with some overlap. So how can we help them? There's the traditional way, and this is a recent study, and I'm emphasizing that. You can see the reference right here, it's from 2020. They looked at 352 college students, and they realized that their perceived stigma is like, how do I think people will think about me if I seek mental health treatment, is the most determining factor, and they're going to seek treatment. They also have their own sense of stigma, but the perceived stigma is the highest, and that's an age where what others think about me matters the most. I highlighted this bit below because I found it mind-boggling, actually. So based upon these student misperceptions of stigma, best practices for addressing stigma within the clinical setting are discussed. Okay, I'll take you on a short trip to Princeton. I don't know if you visited Princeton. That's the Frist Student Center. It's hopping. This is McCosh. You go to McCosh if you have a fever, a mental health issue, or an STD. So how about you go to McCosh and I go get a juice, and then I ask you, oh, what were you doing in McCosh? Which one, right? Do you want to tell me? Do you want me to know that you went there? Probably not. So a major barrier here is actually the exposure. The clinic in and of itself is the barrier for these people in a very small campus where everyone knows one another and everyone is in everyone's business, and being viewed positively by one's peers is of the utmost importance. What Mantra Health did is they created a digital mental health tool for students, for universities, basically acknowledging that students can feel bad not only during work hours. Clinics often find it hard to staff during all hours, and students value their privacy, as well as they're very digital savvy. So they're a wonderful population for digital health. I'm actually amazed. This is rather new. We saw it on LinkedIn maybe a month ago, but it's new and novel. And there are other things that are new. And you can say, well, that's great that they're happening. I can say, yes, but that's a low-hanging fruit, and it has been there for a while. So digital tools are revolutionizing mental health care in the US. That was written in 2020. I'm sure this is truer now than it ever was. But what about people who don't necessarily have access to digital tools, don't feel comfortable with them? Mental Health in America report said that 1/4 of Americans with mental illness reported an unmet need for treatment. What about people who were just blue? They don't have a mental illness, but they have a need. Where do they go? Here's an answer that is quite surprising. They can go to CVS because CVS now staffs their health hubs with social clinical workers. What this does is it removes the barrier to access. You know where CVS is. It removes stigma, both in the eyes of whoever is viewing you and in your own eyes, because it's very normal to go to CVS. And it's bringing it closer, closer than ever. This isn't digital, but it's still, I want to say revolutionary. I want to also laugh at myself for saying it's revolutionary because this is brick and mortar. And why is this so new? But the truth is that it's new, and combining, integrating pharmacy locations with mental health is really novel and helps. And whatever helps, I will vote for it. Okay. Maybe you've seen my post about flexible spending accounts, and I said Amazon made them sexy. Okay, we'll see why in a minute. Flexible spending accounts are a way for Americans to save pre-tax money to allot it for health expenses. And people leave money on the table every single year. 400 million is forfeited every year in flexible spending accounts. More than that is forfeited in health spending accounts. And the truth is that in the year of 2017, only 19% of eligible Americans had a health spending account. Why? This is why. That's probably the most useful graph you'll ever see. It's prospect theory, created by Kahneman and Tversky. What we see here is the lost domain, and it hurts. Losing money hurts more than winning money makes us happy. This is loss aversion, and losses loom larger than gains. How is this related to FSAs? Well, when you have a flexible spending account or a health spending account, you have to understand that you have $2,500 or however much money you have that you need to finish by the end of the year. So are you spending it on your toothpaste, on your dental hygienist visits, eye clinic? What are you spending it on? Have you spent enough money? Have you saved enough money? At the end of the day, most people forfeit money. And the thought of forfeiting money, even though it's pre-tax money, scares the living daylights out of them. They don't want to be there, and therefore they do not use this benefit. The IRS has acknowledged it, and now lets you roll over $500 a year. So I think it's a beautiful example of how taxes relate to prospect theory and our fear of losing. What does Amazon do? So Amazon did something that's really nice. They created a flexible spending account, health spending account store. You can go in the store, you can say, hey, I have money. I'm rich. Hey, big spender, right? Spend something on me, says the FSA store. And you go in and you figure out, what do I need? Oh, Tylenol. Who doesn't need Tylenol? Sunscreen, wonderful. You get all these things. But then Amazon did themselves one over. There's a barrier to using the FSA store. The barrier being you have to remember there's an FSA store, and not everyone remembers that. What does Amazon do? And this is how I discover them. I buy Neutrogena sunscreen. They do not pay me to advertise them. And when I went online to buy it, this little thing popped. FSA or SHA eligible? Yes. Yes, I don't know that many people will just pop with joy to see this, but I did, because I realized what this meant for consumer behavior and how that was driving people to use their money, how it was removing the barriers of remembering that FSA exists, knowing how to use FSA, and it's entirely unappealing to think of buying something and then having the receipt in your wallet and how are you going to use that, and understanding what is eligible and what is not. They removed these three barriers, and there you go, and you can make better use of your money. And that, what I like about that is that it's a win-win. It's a win for me because I can buy my sunscreen with my FSA. It's a win for Amazon because they've helped me do it. And now I know with my health needs, I should go to them because they're linked to my FSA. Wonderful. So far we saw barriers to patient actions. And now the last barrier I'll talk about comes from one of my studies that we did with the Agametrics truly beautiful glucometer. It's gorgeous. It attaches to your iPad, to your iPhone, sorry. Talk about stigma, it removes stigma because it's just cool. You're not some patient, you're a really cool person with a really cool gadget. And it was wonderful to see Sunny Vu, the inventor. We were having dinner with his wife in a restaurant, and he jumped to the car to go get it. He wanted to show me the nugget. He was infatuated with it, and who can blame him? But then I did a study with some colleagues, and we showed it to people who were 60 years old and above. Most of them really liked it, but half of them said, this is great. It's seamless. I don't need to record anything anymore, but my doctor won't know how to use it. How about that? Now, that's one heck of a barrier. And I don't blame these patients. I actually think they are spot on for knowing this barrier. And when I was hosting the Pharma 2.0 series for New York's Health 2.0, interoperability was a word that came up a lot. Like, how do you seamlessly integrate whatever you're doing with your physician? With that, I will stop sharing my screen, and I want to make a swift move to our truly wonderful guest, Dr. Arlen Mayers, who is muted. That's T-shirt of the year, Arlen.
Hi.
So Arlen hails from Colorado. He is the CEO and president of Society for Physician Entrepreneurs, also a doctor and a faculty member at the University of Colorado. And the spirit behind SOAP, Society of Physician Entrepreneurs, that has 6,000 members. And that, my friends, is quite a lot. So I would like to ask you a few questions, and that's a cheat sheet, because for every question that I'm going to ask, I know there's an answer in the form of something that you've developed. And I invite our friends and the people who are with us today to ask you questions as well. So perhaps the first question I will ask, and we started talking about it at the beginning of the webinar, is you mentioned you created a process for second opinion. So what sort of a process is that, and why do patients need it, and why do physicians need it?
Well, thanks for inviting me. It's appropriate because my mother used to call me a nudge, and now we're talking about nudges, so it's a good fit. So to get to your point, I'm involved in healthcare innovation and entrepreneurship, education, consulting, and I work with this nonprofit called the Society of Physician Entrepreneurs. So in the consulting role and in the teaching role, I'm involved in several different companies at various stages. Some of them are drugs, some of them are devices, a lot of them are digital health, some are care delivery, et cetera, et cetera. The one that you're referring to is a company called Ryte, R-Y-T-E Health. It's a Toronto-based company, and it's basically a second opinion as a service platform. So this whole issue of second opinions, so what's the problem? Well, the problem is that second opinions are arguably valuable. In other words, it's not 100% clear that second opinions are indeed valuable. And then the question is valuable to whom? So is it valuable to the doctor? Is it valuable to the patient? Is the doctor valuable to the payer? Is it valuable to the platform? I mean, because at the end, as with all innovations, value is user defined. So it doesn't make any difference what you think as the inventor or the entrepreneur. The only thing that matters is what the customer thinks, and they vote with their wallets. So it's unclear where the value of the second opinion really relies. And there are many, many aspects to this. For example, are mandatory second opinions better, unquote, than voluntary second opinions? An example being that, and each of these statements I'm making are backed by evidence and reports and literature and all that, but there's a study, for example, that shows that if you have a difficult colonic polyp or a difficult colon problem, and there's a definition of that that has to do with the medical aspect of the polyp, and you have a recommendation from a surgeon to do an abdominal colon resection, which is not a trivial affair, it was found that if you are required to mandatorily get a second opinion, the vast majority of those patients could have been managed endoscopically without open surgery. So there's this whole issue of mandatory versus voluntary. And more appropriately to this conversation, you can take a horse to water, but you can't make them drink. The same applies to patients and doctors. So when I say water, I mean, are you willing? Are you able? What is the trigger? What are the issues with expectancy theory and other theories of motivation? And what is your reward for doing what you're supposed to do? Now, this audience it's like me bringing Colts to Newcastle. You guys know a whole heck of a lot more about this than I do. But the fact of the matter is that I deal a lot with traversing the last mile, because a lot of these technologies that are digital health, Zoom, I mean, all of these sort of remote sensing, patient-reported outcomes, SMS messages, calling them on the phone, reminders, you name it. The bottom line is, how do you change doctor and patient behavior to do what they're supposed to do? And we're not talking about manipulating people. We're talking about encouraging them to do what they're supposed to do for their own health and self-interest. Now, when it comes to doctors, to get to your point in the last slide, doctors make technology adoption errors for many, many reasons. And a technology adoption error means you don't do what you're supposed to do, and you do what you're not supposed to do. So it's like statistics. You know, it's like the 2x2 matrix where yes, 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 no. So a type 1 error is you're not doing what you're supposed to do. And what you're supposed to do is typically defined as the standard of care or evidence-based guidelines. A significant percentage of doctors in the United States don't follow evidence-based guidelines, like over 35, 40%. And you got to ask, and contrary, you're doing what you're not supposed to do. It doesn't work. There's no clinical valid evidence that it does, but you're doing it, or you're using something off-label because you think it's going to work. And that can inflict all kinds of mischief, let alone morbidity, and in some instances, death. So why do doctors do what they're not supposed to do? I mean, we're not stupid. Why do we do this stuff? So I have this little thing where I describe it as the ABCDEs of technology adoption errors. So the A is, so I'm a doctor, and I'm an ear, nose, and throat facial plastic surgeon. And I've been practicing medicine for 40 years. So I see a new gadget every day. Somebody presents me with a gadget or a shiny new object or something at a trade show, or you read about it or whatever. And I'm thinking to myself, am I going to incorporate this into the clinical armamentarium? Because I only have, and this is essentially a battle for shelf space in the mind of the doctor. There is, it's like putting a cereal on the shelf of Walmart. They only have so much space. And you have to make a really convincing argument that your product is worth putting on the shelf. So I only have a limited amount of shelf space in my head, because the fact of the matter is 20% or the large majority, it's an 80-20 rule. 20% or 80% of the revenue, for example, of a doctor like me is generated doing 20 operations. So I'm thinking, well, I only have a certain limited amount of shelf space. And likewise, So I'm thinking, so how am I going to decide what to do? So I call it the ABCDE. So the A is my attitude. That is, you know what? I've been doing this for 40 years. Seems to me that my patients are doing okay. Every now and then I get a complication or, God forbid, a death. But that's part of doing medicine. I get it. And if you're not having complications, you're just simply not doing enough surgery. It's just part of the job. So what's the problem? So that's my attitude. The B is biased behavior. And I don't need to tell this group about biases and all that other business. And so I'm thinking, I'm doing fast thinking, not slow thinking. I'm doing type 1, not type 2. And I'm thinking, what's the problem? I think that what I'm doing seems to be working out okay. Of course, there's, like 57 or 130 biases that you guys know like the back of your arm, but that's the issue. Or it's confirmation bias, or, the whole drill. So that's B. C is, and actually the least important, is cognitive. In other words, I might not be aware of what's going on in the world in medicine. So somebody, there's no single human being in this day and age can process everything that's going on in your field. It's just impossible, despite what artificial intelligence gurus seem to be telling us. It's just simply impossible. So I can't process all this. I can't read all the journals. I can't digest all the stuff. I can't really make sense out of the articles at any depth. So number one, and even if I did, and we're aware of the fact that this stuff was out there, I probably would discount it and say, well, the study was blank. It was done in another country. I didn't like the study design. It's not in English. It doesn't apply to my patient. It was a totally different sample. You just go down the list. So I make these cognitive judgments.
If I may, it's a perfect example of the confirmation bias, where you have an opinion and you're going to stick with it. And you can see this in politics, where you cannot change your friends' minds and they cannot change yours. And it's very much the same with other things. We really need to have our opinion hammered out of us in order to have it change.
So that's the C. The D is denial, which is, I just don't see the problem. I mean, I don't, you guys are, and particularly when it comes to the public display of results. So if you want to see, I used to be the chief medical officer of a company that did surgical benefits, was a surgical benefits management company. My job was to herd surgeons. And if there was an outlier in quality, so if there was an outlier and a surgeon A had, an inordinate number of complications or issues, then it was my job to read him the riot act or read her the riot act. And that's not a fun job. Nobody wants their baby. So we're going to say, Dr. Myers, you are below the standard. Well, you know what? Every doctor thinks they're in Lake Wobegon. Every surgeon thinks they are above average. Nobody thinks they are any different than any other surgeon. And if you compare me with everybody else, I'm sure they still have the same complication rate I do, which is in fact not true. But that's the way it is. And finally, the E, which is probably the most powerful one, is emotions. We all buy emotionally and justify rationally. So you present me with a diabetes remote sensing device, and I have an emotional response to that, which is this going to, and I say, if you really want to get into the head of a doctor, you have to knit, I'm a big fan of acronyms because any doctor learns how to do mnemonics to get through medical school. So if you want a doctor to really do something, you have to knit them a quilt, QWILT. You have to present them with something that is a perceived, not actual, a perceived improvement in the quality of care. Number two, you have to do something that is not going to disrupt their workflow. That's the W. Because I know how to do what I do. I got it down pat. I know exactly how to choreograph the visit and don't disturb it. Number three is the I. What's in it for me? Income, gratification, social awareness, your cutting edge and your peer acceptance, peer pressure. What's in it for me? And in these days, COVID, the what's in it for me is money, because it's impacted the income of a lot of doctors around the world. Number three, the next one, so there's Q, quality, W, workflow, I, income, L, do not expose me to malpractice liability if I use this. I got enough to worry about. And malpractice premiums are actually going up in the United States. And I just don't want to deal with this. So if I have to go through a bunch of rigmarole, if I have to learn how to use it, if I have to pass a test, if I have to get approval, if I have to qualify, I'm not real interested in doing something like that, even though it could be the greatest thing since sliced bread. And then finally, the last one, the T, is time. Most doctors want more time on their hands. And actually, they want the time so they can spend more time with a patient, not see more patients. Because right now, as more and more doctors are working for somebody else, the productivity goals are higher. So if anything, doctors are seeing too many patients. The last thing in the world they want is something to help make them see more patients. So what they really want is just something that's going to improve the workflow and eliminate the administrivia so that they can spend more time talking to the person sitting in front of them instead of you're looking at my back while I'm typing into a computer. So that's really how this works in my view. And so when all is said and done, and to get back to the original point, so what does this have to do with second opinions? Well, in general, second opinions should be done in many, many aspects. But the problem, that there are multiple problems with getting a second opinion, with the ability to get a second opinion, with the unequal distribution of the availability of second opinions, with knowing who is in fact the best, unquote, doctor for my problem. And there's three parts to this equation. One is, are you seeing the best doctor? Whether it's the initial expert opinion or a second or a third or a fourth. Number two, the patient, because we're all showing up with biases and prejudices and preconceived notions and value factors and all those sorts of things, particularly in shared decision-making and things where you may have multiple options. So for example, early stage prostate cancer, early stage thyroid cancer, 16 different ways to treat something. How are you supposed to know which one? So what are your values and prejudices and attitudes when it comes to, I present you with a surgical solution, but you had a relative who died on the operating table. And finally, there's your disease. Now, there's some diseases like what I've just described called preference-sensitive conditions that are supposed to be addressed through a shared decision-making process. So I tell you, I'm supposed to be unbiased as a surgeon. My expertise is in oral cancer. You show up to me with a previously diagnosed oral cancer, and I say, I think you should have surgery. Well, I'm a surgeon. You're going to say to yourself, well, of course you're going to say that. You're a surgeon. But you're supposed to be a doctor and give me all the options. Well, it may be that your particular cancer, and these days we're beginning to understand that cancer is not cancer is not cancer. If you have 100 people with oral cancer or breast cancer or pancreas, you name it, the genomics of the cancer are going to vary and your response rate will vary. And I always use the example of pancreatic cancer, which we all sort of say, oh God, you have pancreatic. The 95%, the 5-year survival rate of pancreatic cancer is 5%. It's horrible. But I know a friend, I had a friend who lived 8 years after being treated with stage 4 pancreatic cancer. Why? Because something in her genes, I guess, or all these other multivariables that contributed to her outcome. So the bottom line of all of this is getting people to, the second opinion is only as good as the action taken as a result of it.
Mhm.
And that is that's the last mile. So we can do all this stuff with digital health. We can do all this stuff with remote sensing and monitoring. We can give people advice till they're green in the face. But if they don't do something that is in their best interest, then we've just wasted a whole lot of time.
So Arlen, when we spoke, you said something that I had to write down not because I've never heard it, because I've thought about it, and it was very reassuring to hear it from you, albeit alarming. And you said patient empowerment is a myth. And basically everything you're saying now about prostate cancer, thyroid cancer, et cetera, cases where there are multiple options and where patients need to choose based upon A, knowledge of available options, and B, their set of values as per shared decision making. So I'm wondering, does this process really take place in the second opinion? Can we make sure that it takes place? And from there, I would like to hear from you about remote monitoring, which I think is a process that we can standardize more easily.
Well, the problem that we have, at least in the United States, and I think around the world, because I've been to some places, is as a consumer of healthcare, there's a big emotional block and that is when I tell you you have cancer, for all intents and purposes, you are infantilized. It's like you just totally blank out. In fact, I during my clinical career, if I have to deliver the bad news, I can pretty much rely on the person to not hear what I'm going to say for the rest of the visit. It's just too hard. Like you're resorting to your lizard brain. The conversation is taking place in your amygdala, not in your neocortex. So there's really no point in I'm trying to be nice about it and empathetic, but for all intents and purposes, there's really no point in my saying anything. So what do? You say, well, I know this is hard. Why don't we schedule a follow-up appointment? Why don't you think about this? Why don't you bring some relatives? Why don't you bring a friend? We can give you some information and we can come back and discuss this when you're not totally crazy. Okay, so there's that problem. So there's timing. Now you're supposed to have the information, and unfortunately, the information has to do with quality per unit price because unfortunately, money gets in the way. And if I recommend something that you can't afford or is going to bankrupt you in the American system, which a lot of foreign people have a really hard time getting their head around. But if I tell you to do something and you're looking at literally losing your house, losing your job, going bankrupt, that's going to affect your decision. So this is not an apples to apples comparison. So a low patient IQ, and that's true generally, very few patients really have a pretty high understanding of their disease. It's not their fault. It's a fact. And they have an even lower insurance IQ when it comes to who's going to pay for this, how much is it going to cost, what's going to happen. And oh, by the way, doctors are the same. They're curious, but they're clueless when it comes to cost. So if you ask me, well, Dr. Myers, what's this going to cost? If I give you an answer, I'm probably lying to you or making it up to make you feel better. Because the system is so opaque, you can't possibly understand how much this is going to cost, let alone your ability to pay for it. So I think there's lots and lots of systemic barriers. So the bottom line is, in the best of all possible worlds, patients would have the information they need to make a value or a quality decision that's consistent with their beliefs or their values. Unfortunately, we're a long way from that. And to get to the digital health part, I deal with a lot of companies, and the issue is well, we're going to give you more data, more data, more data, more data. The last thing in the world I want as a physician is more data. I need actionable information at the point of care that will help me make a decision.
Right.
And so do patients. So I'm advocating for a patient clinical decision support system, just like a physician clinical decision support system. And that's basically the gist of the second opinion as a service model. Give you what you need, when you need it, how you need it, in a form you can digest it. Another problem, translating medicalese into fifth grade English or Hebrew or German or whatever.
Absolutely.
People can't understand what we're talking about.
Absolutely. This is definitely it's like you're checking off all the boxes, and I'm happy because I'm checking off the boxes in what I wrote with the medicalese, etc., with the language, with the decision processes, with the, and I sometimes think it's funny that people want to free the data and to have a lot of data, and as though that's so wonderful. And then what are you going to do about it? How are you going to make sense of it? And how are you going to know that the sense you're making of it is really truly actionable and accurate? And I want to thank you. I could listen to you for the next 4 hours, and I would be fascinated. And I think Lynn feels the same way, as does Tanya. And I'm sure the others do too. And I would like to open the floor to questions. Questions for Dr. Myers, questions for me, or anyone who just wants to say anything before we sign off and talk about next session. Yeah, go ahead, Lynn.
I have one, I guess it's more a comment or an observation than a question, because I completely agree with everything that you said, and I'm very excited to hear it presented in such a straightforward way that actually could be communicated to patients almost exactly as you said it. So I really love that.
Thank you.
I don't think that we have dealt with the barriers within the interpersonal dynamic of a clinician and their patient. And that happens at the point of care. And so what do you do with a patient that worries that if they ask for a second opinion, they're going to alienate the first opinion doctor? It doesn't happen with so much in specialty care, where that might be the first time that you ever saw that doctor. If you have anything remotely like a long-standing relationship with your clinician, that to me is a barrier.
So 2 points. One, in my view, there is no doctor-patient relationship. And that may sound fairly controversial, but the medicine has changed so much. And it's not the old Marcus Welby. I've seen you for 40 years. I trust everything you're doing. I know, like, and trust you, all that. It's just gotten too complicated. It's been corporatized. It's been chopped up into a bunch of little pieces. And you see one doctor here, you see another doctor there, you may see a nurse practitioner, you may see somebody else in the hospital, you see somebody else in the ICU. There's a whole team of folks that you're seeing, and it's difficult to establish a relationship with any one of those people. And generally, the level of trust throughout the world in institutions has eroded. And the OECD does these things every year, whether it's government, whether it's doctors, whether it's, you name it. Trust has been eroded. And depending on, in our case, who's the president of the United States or whatever, it's back and forth. So there's that issue. The other point I want to make is that you folks are a lot more familiar with this issue of psychological safety than I am. But, when you look at the literature on high performance teams and Project Aristotle, which was the Google thing, why do some teams perform better than others? What percolated to the top was psychological safety. In other words, I can say whatever the heck I want, and I'm not going to feel like I'm going to get my head handed to me, regardless of how outrageous what I'm saying. Because that person may not be buying into the groupthink, and in fact has the right answer. But if you don't allow that and jump all over them, it gets to do with this inclusion thing. There's a lot of talk about diversity, equity, and inclusion. Well, the inclusion means you're listening to what I'm saying. If you don't listen to what I'm saying, then we're going to have a problem. What does that have to do with what we're talking about? If I'm the doctor and you're the patient and you're afraid to ask me for a second opinion, that's not psychologically safe. So there has to be some psychological safety built into the relationship, into the interaction. And the way to do that, it's a preempt, in sales, it's a preemptive close. I understand that this is coming as a big shock to you, this diagnosis of cancer that I just gave you. You have a complicated condition. There are multiple therapeutic options, and perhaps you'd feel more comfortable getting another opinion. If you would like that, I'm happy to provide people that I think, or you're free to find, just so I won't introduce any bias. If you don't trust me, parentheses, then, and there's also the issue that in many respects, patients who seek second opinions are actually seeking second doctors. They simply don't trust or like the person who is staring them in the eyes.
Roland, I think that's a harsh interpretation. I think this really gets in the way of how physicians feel and probably how patients feel. I want to take the final question from Michael Millinson. Go ahead, Michael.
So real quickly, I want to sort of agree with what Dr. Myers said in his second half, but not in the first. I think psychological safety says it, and that's always been true. The whole idea that doctors had this golden era in behalf, I've done a lot of research this. As you can see, I have a gray beard. Medicine was always better when the people who are now over 50 were 20. Everything, Dr. Welby, in fact, which our people use, the AMA was so worried that people thought that would be real that they objected to the show. And then it turned out that everybody thought it was real and it's still used. So the psychological side, the question is right. In fact, we talk about, Talya started talking about this group of smart people, right? So there was a study done in Palo Alto, right? Smart, high picket, and like they asked them, when you ask your doctor and disagree with your doctor, would you think you should? 85% yes. Would you do it if your doctor sort of, would you actually challenge your doctor? Like all of them said no. Because when you're in there, you don't necessarily feel psychologically safe unless, as you said, they really let you do that. And so, and the question is, how can we get doctors to do that? And I know that my sister, I'll give a quick example, I'll let you talk, graduate degree, MBA, or husband, a graduate degree, being treated for a type of cancer where the drug that the doctor was prescribing didn't work. And I found an expert who had something better, and she was afraid to bring it up with her doctor, that he would not like her. And I said, do you love your doctor enough to die for him? Right? And she brought it up with him and he was fine because he knew that she was suffering. But I think the challenge that you're raising, and the second opinion in particular, you framed it. How do you let doctors feel comfortable with it and patients feel comfortable with it, that it is not expressing a distrust that is unfair, disruptive, punitive, whatever, right? And that's kind of, the real question. And you framed it beautifully. I'm above average. How can you go to another doctor? They can't be as smart as I am, right? So how do you give psychological safety to doctors and patients?
Well, and it goes beyond, and this will be a final point, it goes beyond the psychology. There's a practical implication.
Right,
and that
absolutely.
is, in the United States, you may not be able to find another doctor. So if you don't stick with me, you're out of luck. I mean, that's a reality. So there's always that, how do I balance?
Or you're taking away business from me by going to another doctor. That's on the other side.
That's a whole other story with medical travel. And you want me to take care of you when you went to Costa Rica to get your whatever.
Yeah. But even if we set aside the fact, I like going to Costa Rica for whatever, I like that actually a lot. But even if we put aside access to care and financial issues, I think the whole issue of psychological safety and relationship, which you said, Arlen, does not exist. Well, it does exist, as we hear from Michael. People do care. People don't want to alienate their physicians. Physicians, I'm sure, don't want to feel alienated or disrespected. And if this is how they perceive a doctor, a patient asking a question, then we're in trouble. And actually, this is a great segue for our next session, which will again be on the last Thursday of the month. It's happening in May, on May 27th, and it's going to be on health literacy, which is a secret weapon, really. And I want to talk about some hidden aspects of health literacy that may not be all that familiar with. So as always, I want to thank everyone for participating and being with us today. First and foremost, to Dr. Arlen Mayers. Really, it's a pleasure as always and more.
Thanks for inviting me.
And anytime, like seriously. So this is the next session. This is my email address, and you can find me on LinkedIn, and I'm more than happy to discuss with anyone the topics that came up today and future sessions. And with this, I want to bid you all farewell and thank you for your time.
Thanks.
Thank you.
Thank you.
Thanks, everyone. Thanks, Wani. Nice meeting you.
You too.
Thank you. See you soon.
Yes.